We're starting out today with Dr. Anna Rutherford, who's an assistant professor of medicine at Harvard Medical School and the clinical director of hepatology at Brigham and Women's Hospital. Her clinical interests are in acute liver failure, advanced liver disease, and liver disease in pregnancy. And she is here to do a review of care of patients with cirrhosis for the Hospitalist. So welcome, Dr. Rutherford.
Thanks so much, and good morning, everybody. So today I'd like to cover the following topics: a little bit about the natural history and outcome of cirrhosis in general, some initial management of complications of cirrhosis and updates in recent studies on management of complications of cirrhosis, and then a turn to talk a little bit about appropriate timing of referral for liver transplantation and preoperative risk assessment in patients with cirrhosis. We're going to start with patient RS, who is a 52-year-old with alcohol and hepatitis C related cirrhosis. He has had his hepatitis C cured, and he's been sober for 5 years. He recently developed ascites and is now on furosemide, spironolactone, and a low-salt diet. His family thinks he's unsafe to drive due to inattention, so he was recently also started on lactulose. He comes into the emergency room with diffuse abdominal pain and distension and confusion. While he's being evaluated in the emergency room, his wife asks you how long he can live like this. So in patients with chronic liver disease of any etiology, viral hepatitis, autoimmune liver disease, alcohol fatty liver disease, or metabolic fatty liver disease, over time, a proportion of patients will develop compensated cirrhosis. As portal pressures increase, a proportion of those patients will develop decompensated cirrhosis. The most common ways patients decompensate is development of ascites, jaundice, encephalopathy, or variceal hemorrhage. And as soon as someone develops decompensated cirrhosis, we have a sense that their life might be limited by their liver disease. This may be the cause of their death. If you follow patients with a new diagnosis of cirrhosis over 10 years, nearly 60% of patients will have an episode of decompensation. The most common is ascites, followed by jaundice, encephalopathy, or variceal bleeding. Some of the risk factors for hepatic decompensation or causes of an increase in portal pressures include GI bleeding of any sort, any type of infection, ongoing alcohol use, medications, dehydration, constipation, obesity. It is been shown that a patient with a body mass index greater than 30 has a marked increased risk in hepatic decompensation, probably because obesity increases portal pressures. Any type of surgery or ongoing viral infection, and by that I mean talking about viral hepatitis B, C, or D. So we are interested in hepatic decompensation because we know that it reduces survival. Here, curve A is a patient with a new diagnosis of cirrhosis who has remained compensated. As soon as a patient has their first episode of decompensation, their median survival drops to 1.6 years. We're pretty good at predicting survival in patients with cirrhosis. So the initial MELD score, which is the equation down below with the natural log of the bilirubin, INR, and creatinine, is very good at predicting 3-month survival in patients with cirrhosis. Here you can see a patient with compensated cirrhosis probably has a MELD score in the low teens. Patients with MELD scores in the 30s to 40s, which is where we are transplanting patients in region 1, where we are patients with very decompensated cirrhosis. And you can see their 3-month survival without a liver transplantation is significant. We're also pretty good at predicting 1-year survival in patients with cirrhosis. And for this, we use the Child-Turco-Pugh score, which gives points for amount of encephalopathy and ascites, as well as bilirubin, albumin, and INR. Here, a patient with Child's A cirrhosis is a compensated patient with cirrhosis, have 100% 1-year survival, versus a patient with Child C cirrhosis has a 45% 1-year survival. So I'm going to start talking about the complications of cirrhosis. In patients with cirrhosis, eventually portal pressures will increase probably to a threshold of 10 millimeters of mercury, and we'll come back to that, which is now called clinically significant portal hypertension, and a proportion of patients will develop uncomplicated ascites. 50% of patients with compensated cirrhosis will develop ascites within 10 years of their diagnosis, and this is associated with a reduction in 5-year survival from 80% to 30%. Ascites is also the most common complication of cirrhosis that leads to hospital admission, and any patient with new onset ascites requires a diagnostic paracentesis with the measurement of at least 4 things: cell count and culture to exclude infection, an ascites albumin, and an ascites total protein. Despite the fact that these patients have a bleeding diathesis related to their liver disease, bleeding complications are extremely rare, both in a diagnostic paracentesis or a therapeutic paracentesis, which is a larger bore needle. And the use of blood products, looking at large studies of patients with very high INRs, very low platelets, for any type of paracentesis is not data supported. A serum ascites albumin gradient of at least 1.1 is 97% accurate for diagnosing ascites related to portal hypertension, and a high ascites total protein of at least 2.5 is suggestive of cardiac ascites. And that's why we want to measure those in every patient for their first paracentesis. So treatment options for patients with cirrhosis with new ascites. If patients are still drinking alcohol, cessation of alcohol use can really help manage ascites and lower portal pressures. The light blue colored suggestions here should be effective in about 90% of patients. So a sodium restricted diet, 2 grams of sodium a day, and education about what that means. This is perfect on the inpatient setting when patients can have a nutrition consult to sort of really discuss what they're eating in their diet and how much sodium there is. There is some data in patients who are diuretic naive that spironolactone 100 milligrams alone may be effective in managing new ascites. More typically, we start dual diuretics, spironolactone and furosemide, orally with a single daily dosing. We use a ratio of spironolactone 100 milligrams to furosemide 40 milligrams, mostly to balance sodium and potassium levels, and it's reasonable to increase these every 3 to 5 days, assuming that you're getting some management or not getting enough management of the ascites. Fluid restriction is really not something that is a part of management of ascites per se. Don't recommend it unless you're dealing with hyponatremia, for which it is a reason to manage. So serum sodium of less than or equal to 125 might want to consider fluid restriction then. High-dose diuretics or maximum dose diuretics are spironolactone 400 milligrams and furosemide 160 milligrams, just for some context. Patients do develop tender gynecomastia with spironolactone, so amiloride or eplerenone are often substitute. Anecdotally, I would say that spironolactone is probably more effective if patients can tolerate it. Because we're interested in perfusing the kidneys and keeping blood pressure up to help with diuresis, in a patient with new ascites, consider stopping things like NSAIDs, ACE inhibitors, ARBs, or propranolol, or non-selective beta blockers. Because this is an episode of decompensation, this might be a time to start considering liver transplant evaluation or discussing it. And I just wanted to mention 2 studies, the ANSWER study and the MPH study, which looked at albumin infusion in patients with cirrhosis and ascites. So this is not standard of care. This is a study where these patients are not receiving albumin infusions for management of refractory ascites or large volume paracenteses, but were assigned with an albumin infusion once or twice per week, in addition to diuretics for managing their ascites. The ANSWER study showed that this reduced hospitalizations, reduced episodes of acute kidney injury, and overall improved mortality. The MPH study showed no benefit to giving albumin. As I said, this is not standard of care, but certainly something that has been looked at in these patients. So over the last few months, RS has been unable to receive diuretics due to hyponatremia. What are the other management steps that might be considered for his ascites? Here, 1, TIPS, 2, large volume paracentesis with albumin repletion, 3, liberalizing his 2-gram-a-day sodium diet, 4, urgent liver transplant listing, refractory ascites gives extra listing points, or 5, increasing his non-selective beta blocker. There might be more than one answer for this. And it looks like most people are okay. It looks like most people are getting the right answer. The correct answer is 1 and 2. Just looking down below, particularly point 4, there are no extra points for liver transplant listing or exception points for refractory ascites, unfortunately. So this patient is developing refractory ascites. It's about 10% of patients with cirrhosis who have ascites who will develop refractory ascites. And the definition is unresponsive to a 2-gram sodium diet and high-dose diuretics, or clinically significant complications of diuretics, which include encephalopathy, elevated creatinine, hyponatremia, and hyperkalemia. For these patients, options include serial large volume paracenteses or consideration of TIPS, potentially as a bridge to liver transplant if these patients are transplant candidates. In patients receiving large volume paracentesis of at least 5 liters, it's recommended that they receive albumin infusion 6 to 8 grams per liter removed. This improves survival and also prevents something called post-paracentesis circulatory dysfunction, which is really sort of large volume shifts potentially triggering an acute kidney injury. The use of non-selective beta blockers in patients with refractory ascites has conflicting data. General rule of thumb is that it should be reduced or discontinued if a patient has a systolic blood pressure of less than 90 millimeters of mercury or is presenting with acute kidney injury. So a few words about TIPS for management of refractory ascites. This stands for the transjugular intrahepatic portosystemic shunt. It is placed through the internal jugular vein. A catheter is threaded down the IVC into one of the branches of the hepatic vein. A shunt is placed through the liver till it connects with one of the branches of the portal vein. The idea here is that blood flow that was somewhat impeded by the cirrhosis is now able to flow more smoothly through the liver and not back up into collaterals and cause things like ascites or varices. So there have been several recent meta-analyses looking at TIPS or large volume paracentesis in patients with refractory ascites, and there seems to be a survival advantage for TIPS in select patients. TIPS is not an immediate fix. It causes a gradual suppression of neurohormonal vasoconstrictors over 4 to 6 months. By 6 months, about 80% of patients will clear their ascites. So this involves careful patient selection. The MELD score is actually created to determine who would do okay or who would survive TIPS placement, the original MELD score. So a MELD score of less than 18 is favorable for thinking about a TIPS. Patients with a MELD over 18 who have hepatic encephalopathy, which a TIPS can predispose one to, advanced age, cardiopulmonary insufficiency, or sarcopenia are at greater risk of complications post-TIPS and certainly warrant a conversation. What we have found is that TIPS stents with a smaller diameter, 8 to 10 millimeters, have been equally effective in ascites management. So lower portal pressure is enough to manage ascites, but reduce the risk of hepatic encephalopathy. And so placing a TIPS certainly involves assessment of the patient overall, checking a MELD score, and also discussion with vascular radiology, who typically places these TIPS, about size and risks of encephalopathy and management of ascites. So RS has an admission sodium of 121. His creatinine is elevated at 2.1, and he has evidence of spontaneous bacterial peritonitis on his diagnostic tap. In addition to starting ceftriaxone, your next steps in management should include number 1, stop natalol, number 2, albumin infusion, number 3, check urinalysis, number 4, start pentoxifylline, and number 5, 1, 2, and 3. Wow, looking pretty good there. So the correct answer is 5, 1, 2, and 3. Here in this patient with a new diagnosis of SBP and acute kidney injury, the concern is evolving hepatorenal syndrome. It took me a long time in my liver training to sort of understand that hepatorenal syndrome is actually part of the spectrum of ascites, and certainly follows from patients who have refractory ascites. The clinical features, you must have cirrhosis, you must have ascites, you have to have a diagnosis of acute kidney injury, no creatinine improvement after 2 days of diuretic withdrawal, and no creatinine improvement after 2 days of volume expansion with albumin ideally. So 1 gram per kilogram of body weight daily for 2 days. Patients should have no evidence of shock or nephrotoxins, and if urinalysis is done, really bland urine sediment and no signs of structural kidney injury. So the natural history of hepatorenal syndrome. There is now type 2 hepatorenal syndrome, and then type 1 hepatorenal syndrome is now called HRS-AKI. So type 2 hepatorenal syndrome are patients with refractory ascites. Their main issue actually is management of refractory ascites. Their creatinine is elevated, perhaps preventing them from receiving diuretics, and they're receiving therapeutic paracenteses, hopefully with albumin infusion. There's usually some event here, SBP, very common one, some type of infection, a surgery, a very large volume paracentesis and big fluid shifts, perhaps a GI bleed. And patients have a marked rise in their creatinine and development of oliguria. And here, they may be evolving from type 2 hepatorenal syndrome into HRS-AKI. How do we manage this? If patients have a type of liver disease that can be treated, alcoholic hepatitis or hepatitis B, certainly starting to treat them. Other things we can do to prevent evolving HRS-AKI, giving albumin infusion in patients with spontaneous bacterial peritonitis, stopping non-selective beta blockers, again, to sort of protect the fragile kidneys. If we have given albumin trial for 2 days and there's no improvement in creatinine, we start thinking about giving a vasoconstrictor drug in combination with albumin. The most effective is terlipressin, which was approved to use in the US in September of 2022. It's been used in Europe for a lot longer than this. Norepinephrine and albumin, which obviously requires an intensive care unit, is equally effective to terlipressin. Thankfully, terlipressin is now available because it replaces the much less effective albumin octreotide and midodrine, which is what we had been using as patients were in the intensive care unit. So renal replacement therapy as a bridge to liver recovery or liver transplant is certainly appropriate in these patients with HRS-AKI, and liver transplantation is obviously the one cure for these patients if they are appropriate transplant candidates. So just a few words on spontaneous bacterial peritonitis. Obviously, anyone with ascites is at risk of developing SBP, and it is certainly one of the larger triggers for hepatorenal syndrome. So we typically use systemic antibiotics for community-acquired SBP, ceftriaxone or cefotaxime. Avoid aminoglycosides, again, because of the fragility of the kidneys in these infections. Most patients will respond to a 5-day course of treatment. There are different guidelines suggesting whether patients get a repeat tap to see if the treatment is effective. And some studies support one on day 3. I would say in general, if a patient is not clinically improving, and by looking at things like the MELD score, the kidney function, it would be reasonable to do a repeat tap to make sure that you are treating or you have the correct antibiotic. There is good data to support stopping non-selective beta blockers for the period of the acute infection in these patients. And there is also data to support giving albumin infusion on day 1 and day 3, particularly in patients with elevated BUN creatinine or serum bilirubin. But if patients are hospitalized with SBP, it's reasonable to give them albumin infusion on day 1 and day 3 of an infection. So a few words on primary and secondary prophylaxis. So any patient with cirrhosis who is decompensated, Child's B or C, who's hospitalized with GI bleeding of any sort should be receiving primary prophylaxis. Other patients who probably warrant primary prophylaxis who have an ascites total protein of less than 1.5, as well as renal failure or liver failure. Patients with a prior history of SBP should certainly receive secondary prophylaxis. We typically use trimethoprim sulfa daily or ciprofloxacin daily. There have been studies looking at intermittent or weekly dosing of antibiotics, and I think both for adherence purposes and also some concern for resistance, they can be effective, but are probably inferior to daily dosing. So RS is being treated for SBP, but his encephalopathy persists. Lactulose was held on admission due to concern for intravascular volume depletion. Other potential treatment options for encephalopathy include number 1, hemodialysis, number 2, rifaximin, number 3, 4 liters of polyethylene glycol, number 4, neomycin, and number 5, protein restriction. Okay, that seems pretty definitive. That is the correct answer. Rifaximin is probably the best option. Just going through the other ones, hemodialysis can lower ammonia levels, but is not an hemodialysis. It's not an indication. Encephalopathy is not an indication for hemodialysis, except in acute liver failure. Interestingly, 4 liters of polyethylene glycol or a go lightly preparation is effective in reducing acute hepatic encephalopathy, but it involves giving a patient who's encephalopathic a full colonoscopy prep, which requires NG tube, etc. Neomycin is also effective in treating acute hepatic encephalopathy. However, there are some concerns about kidney dysfunction, particularly in this patient. And protein restriction actually is not recommended for management of encephalopathy. In fact, these patients should be receiving high protein diets due to the catabolic process of their liver disease. So how do we treat hepatic encephalopathy? For the most part, there is a precipitant. The most common precipitants are infection of any type, electrolyte abnormalities, any type of GI bleeding, constipation, dehydration, or use of sedatives. So if we can identify what might be the precipitant and treat that, that's probably half the battle. The goal is to lower ammonia level. We typically start with lactulose, aiming for 2 to 4 bowel movements daily. More is not better, as it can lead to electrolyte abnormalities, etc. And rifaximin can be an additional and stronger and more effective and probably better tolerated way to treat acute hepatic encephalopathy. As I mentioned, do not restrict protein, maintaining a dietary protein intake of 1.2 to 1.5 grams per kilogram per day for these patients because of the catabolic nature of their liver disease. And once you have ascertained that the patient has encephalopathy and perhaps measured an initial ammonia level, it's reasonable to use the physical and neurologic exam rather than following serial blood ammonia levels, because they can often lag behind what you're seeing clinically. So on day 2, RS has massive hematemesis. He has an urgent endoscopy that shows grade 3 esophageal varices with red whale signs. He has 3 bands placed. Next steps should include all of the following except number 1, IV octreotide for 72 hours. Number 2, consider TIPS before he rebleeds. Number 3, transfuse to keep hemoglobin greater than 10. And number 4, continue ceftriaxone treatment for SBP. So, excellent. The correct answer, or what you don't want to do, is transfuse to keep hemoglobin greater than 10. So just a few words on it, managing acute GI bleeding in patients with cirrhosis. This really depends on the location, severity, and degree of the hemostatic impairment. If patients are determined to have a variceal bleed, either esophageal, gastric, sometimes rectal, the major cause of these bleeds is increased portal pressures rather than the bleeding diathesis. In patients who have non-variceal bleeding, diverticular, peptic ulcer disease, here we're really focused more on the bleeding diathesis of patients with liver disease. So managing the INR, the platelet count, and the fibrinogen level. It's reasonable to give vitamin K, transfuse to keep a platelet count greater than 50,000 in acute bleeding, give a source of fibrinogen to get the level between 1 and 120 at least, and consider an antifibrinolytic in patients with massive GI bleeding, something like tranexamic or aminocaproic acid. Thrombopoietin receptor agonists are approved for management of bleeding, but they are not effective in the acute setting because they take about 5 or 6 days to boost a platelet count. So managing acute variceal hemorrhage of any site, these patients should probably be in the intensive care unit. Standard of care is that they receive an upper endoscopy within 12 hours. They should probably usually be intubated. And there's good data to support a restrictive blood volume resuscitation. So starting to transfuse patients at a hemoglobin of 7 and keeping the hemoglobin between 7 and 9. Greater than 9 grams per deciliter can sometimes increase the risk of rebleeding. These patients should be receiving SBP prophylaxis, and they should also be receiving a vasoactive medication, octreotide, somatostatin, or terlipressin, depending on the institution, for at least 2 up to 5 days, with likely transition to a non-selective beta blocker. And there's good data, though we use this less, to support TIPS in these patients with Child's C cirrhosis or Child's B cirrhosis with active bleeding. So here are some large esophageal varices on the left, and here is banding, which is literally a little rubber band that is placed around the varix to cut off the blood supply. Eventually, these slough off and leave an ulcer there over 5 to 7 days. So I wanted to talk a little bit about early TIPS as an option for variceal hemorrhage. So this is in patients that you have done standard of care. You've put them on vasoactive medications, they've had endoscopic therapy, they've been banded, and you may feel that their bleeding is under control. There's been a number of studies more recently than this one, but this is sort of the most clear cut. It came out in the New England Journal in 2010. They looked at patients with Child's B and C cirrhosis, so quite decompensated with acute variceal bleeding. All of them received what we talked about here, vasoactive medications and endoscopic therapy. And then half of them were randomized to undergo a TIPS within 72 hours of admission. The other half continued to do what we tend to do, I would say, on the inpatient side of things, give them vasoactive medications, transition to a non-selective beta blocker, and continued banding as an outpatient. Of the second group, 7 needed a rescue TIPS, even within this hospital admission for rebleeding. The median follow-up was 16 months. And at 1 year, there were no big differences between the group that received the TIPS or pharmacologic therapy in terms of encephalopathy, which is always a concern about TIPS. And there were no significant differences in adverse events. What was very different, and probably the most striking, was the reduction in rebleeding. So patients who received an early TIPS had no rebleeding, whereas patients who had the conservative management or more conservative management over 2 years, 50% of them had rebleeding. And this really impacted their survival. So the patients who had the early TIPS, 86% survival at 2 years, whereas patients who had recurrent bleeding or did not have the TIPS had 61% survival at 2 years. This is probably the most clear cut. I would say when this came out, there was sort of a pivot to doing more early tips in management of variceal bleeding. And then it sort of fell off. And now there's been a re-look at these studies over the last 4 or 5 years. Again, the data has borne out that patients do benefit from a TIPS in this situation. And now the studies are sort of looking at why institutions are not doing that. And I don't have a perfect answer for that, I will say. So if the endoscopy on RS showed isolated bleeding gastric varices, what would your treatment options include? Number 1, consult vascular radiology for TIPS. Number 2, consult vascular radiology for a BRTO. Cyanoacrylate glue injection. Number 4, continue IV octreotide and proceed with urgent transplant evaluation. Or number 5, 1, 2, and 3. Excellent. So the correct answer is 1, 2, and 3. Just a few words on bleeding gastric varices. So same initial management. You probably won't know whether it's esophageal or gastric or both until you do the upper endoscopy. So these patients should receive vasoactive drugs, restrictive transfusion protocol, and antibiotic prophylaxis. Banding gastric varices can be technically more difficult. The further away they get from the GE junction, the larger they are and the more difficult they are to pull into the endoscope and place a band around. So we have other sort of local measures that we can use in patients with gastric varices. So cyanoacrylate glue injection, where you basically put a needle right into the varix and inject this glue. It polymerizes into a firm clot. There is a risk of distal embolization in these patients, and it's actually not approved by the FDA for use. Those centers do use it depending on expertise. TIPS, which globally lowers portal pressures, is a very good thing to consider when patients have gastric varices, but there are also more localized approaches. So one that we use more frequently in patients with isolated gastric varices is BRTO, balloon-occluded retrograde obliteration. This relies on the fact that a large number of these patients have spontaneous shunts, renogastric shunts. So they're able to place a catheter through the renal vein into one of the gastric veins and instill a sclerosant or a sponge. This has 90% long-term bleeding control of gastric varices. The issue is if patients have large esophageal varices or other complications of portal hypertension, this can worsen those because you're closing off a spontaneous shunt. So this is definitely worth thinking about in patients with isolated gastric varices, but if they have large esophageal varices or you're not sure where their bleeding has come from, this is probably not the best option, and you want to think about something more global like a TIPS in terms of lowering portal pressures. There's also center-dependent endoscopic ultrasound-guided coiling of gastric varices where they place metal coils in the varices through the esophageal wall. So a few words on gastroesophageal varices, because guidelines and management of this has really shifted or evolved in the last couple of years in terms of how we manage esophageal varices. So patients with cirrhosis, 50% of them will have gastroesophageal varices. 30 to 40% of patients with compensated cirrhosis, 85% of patients with decompensated cirrhosis. And in patients with compensated cirrhosis, varices develop at a rate of 7 to 8% per year. We now have this new entity. It's not that we call clinically significant portal hypertension, and this is assuming that patients have a hepatic venous pressure gradient of at least 10 millimeters of mercury. This is where we think ascites is more likely to develop and or varices. So you can diagnose clinically significant portal hypertension in a couple of different ways. If patients have an episode of clinical decompensation, you can assume they have clinically significant portal hypertension. If they have varices on endoscopy, if they have portosystemic collaterals or hepatofugal flow on imaging, those are all sufficient to diagnose clinically significant portal hypertension. We now have a way in our clinic to diagnose this, which is by use of elastography plus a platelet count. And basically, if patients have an elevated liver stiffness and a low platelet count, so a liver stiffness of 15 to 20 plus a low platelet count, this can be considered clinically significant portal hypertension. If a patient have a liver stiffness of greater than 25 kilopascals, that by itself diagnoses clinically significant portal hypertension. And this plays into how we manage these patients on the outpatient setting primarily, but also on the inpatient setting. So anyone with a new diagnosis of cirrhosis, traditionally, we would recommend an endoscopy to screen for varices. Now, these patients can have an elastography and a platelet count to assess for clinically significant portal hypertension. If patients have any type of varices or clinically significant portal hypertension by elastography, the recommendation is to start carvedilol, 6.25 milligrams daily, and increase it to 12.5 milligrams daily if tolerated. The nice thing about carvedilol is you can give it once a day, even though it's usually a twice-a-day medication. We don't have to worry. There's enough data to support its use that we don't have to worry about lowering heart rates or blood pressures significantly. You can start patients on these, and if they can tolerate it, meaning they're not getting hypotensive or symptomatic, and you can get it up to 12.5 milligrams a day, you can feel pretty comfortable that their portal hypertension is likely being treated. So if there's no varices on the original endoscopy, we typically would repeat this every 2 years with ongoing liver injury, because we know that varices do evolve at a good rate per year in patients with compensated cirrhosis. Or you can repeat the elastography and platelet count annually. I would say these guidelines came out at the end of 2023. So there aren't a lot of patients that we've yet been doing the annual elastography and platelet count, but this is certainly plays into our discussions with patients in clinic about whether they want to undergo an endoscopy or whether we should just do this and start carvedilol if they don't have a contraindication. Endoscopy is also recommended at the time of clinical decompensation. I think we can, looking at these guidelines, also assume clinically significant portal hypertension and consider carvedilol depending on what else is going on. If their patients have cirrhosis, but they don't have varices on the endoscopy and they don't have signs of clinically significant portal hypertension, there's no data to say we should put these patients on carvedilol. We basically want to manage their liver disease in hopes of preventing clinical decompensation. In patients with grade 1 varices, these are small varices that are unlikely to bleed. Usually it's recommended to start them on a non-selective beta blocker. Carvedilol is preferred. And if it's tolerated, again, no need to repeat the endoscopy. Grade 2 or 3 varices, larger, like the ones in the picture, are more likely to bleed. So these patients might be managed by a non-selective beta blocker or variceal ligation. It sort of depends on the clinical context. So RS is slowly recovering from his SBP and his variceal bleed. He's been on IV ceftriaxone for 5 days and then has transitioned to secondary prophylaxis. His creatinine slowly normalizes. He transitions from IV octreotide, and there's debate about restarting nadolol. He's had a variceal bleed, but he's also just had acute kidney injury, and he has refractory ascites. Often in these patients, it's worthwhile letting them stay off the non-selective beta blocker for a couple of days and then considering restarting it as an outpatient. His encephalopathy improves with the initiation of rifaximin as well as treatment of his electrolyte abnormalities and his infection. His MELD score is 19. His wife asks you what else can be done. The big question here is whether he is a liver transplant candidate. The optimal time to refer someone for liver transplant is when they have an episode of clinical decompensation, as well as a biochemical decompensation, a MELD score of at least 15. So this patient has had numerous episodes of clinical decompensation. The most common ones are encephalopathy, ascites, variceal hemorrhage. Hepatocellular carcinoma is considered a decompensation, hepatorenal syndrome, hepatopulmonary syndrome, or portopulmonary hypertension. And we know that each of these are likely, as soon as someone develops decompensation, their life might be limited by their liver disease. Other things that we refer for liver transplant that are not really relying on clinical decompensation: acute liver failure, severe alcoholic hepatitis, and poor quality of life or recurrent resistant infections in patients with primary sclerosing cholangitis or polycystic liver disease. So what is the MELD score? It stands for the Model for End-Stage Liver Disease, and as I mentioned previously, it was originally created to predict short-term mortality post-TIPS placement. It's been the basis of liver allocation in the United States since 2002, though the MELD score has evolved in hopes of better predicting waitlist mortality. So the MELD sodium was started to be used in January of 2016, and most recently, the MELD 3.0 started to be used in July of last year. The MELD 3.0 involves 5 objective lab tests: sodium, total bilirubin, creatinine, INR, and albumin, and also gives consideration for gender. It's highly predictive of 3-month mortality in patients with cirrhosis, which I think is why it has been used for liver allocation. And what we know is that the MELD score of 15 is where there's a threshold, there's a survival benefit. So patients with a MELD score of 15 or greater will live longer with a liver transplant than without it. And that is why when we're thinking about who to refer for transplant, we want patients with both decompensated cirrhosis and a MELD score of at least 15. So if you look at the etiologies of adult transplant recipients in the United States, the two biggest categories, and they are sort of neck and neck most years in terms of etiology, are alcoholic liver disease and metabolic fatty liver disease. Hepatitis C used to be the #1 indication until we had directly acting antivirals, which allowed us to treat patients with decompensated cirrhosis prior to transplant. Exclusions for transplant: a MELD score of less than 15, again, because of the survival benefit. And basically, these patients have to have a very sick liver and an otherwise pretty healthy body. So they cannot have severe cardiac or pulmonary disease that is not related to their liver disease. They can have HIV infection, but patients with full-blown AIDS do not do well post-liver transplant because of the immunosuppression. Ongoing alcohol or illicit substance abuse, liver cancer that spread beyond the liver, uncontrolled sepsis, some sort of anatomic abnormality that precludes transplant. Intrahepatic cholangiocarcinoma has traditionally not been a reason to do transplant, though some centers are starting to have a protocol to consider this. Extrahepatic malignancy, and thus it's extremely remote with a low risk of recurrence. Persistent noncompliance and lack of an adequate social support system. So these are things that the full liver transplant team takes into consideration when evaluating any patient. So RS is listed for liver transplant with a MELD score of 19. His family wants to know how long until he gets a deceased donor liver transplant and what he can do to increase his chances of receiving a transplant. So here is a map of the United States. Since liver transplant became commonplace in the 1980s, they divided the country into 11 regions, UNOS regions, United Network of Organ Sharing. If an organ becomes available in a region, it goes to a patient in that region. And as you can see, they haven't changed the boundaries of these regions very much since the 1980s, unfortunately. But as you can see, there are a large variations in number of liver transplants that are done each year in each different region. Region 1, where we are, has the second least number of transplants compared to the Pacific Northwest. And patients in regions 3 and 5 have the most liver transplants. There are a lot of reasons for this, but what it really translates into for our patients is, if you're waiting, there's only 400 organs here and there's 1,800 here, your MELD score is going to be much higher before you get an organ. In Region 1, we offer transplants to patients with a MELD score of at least 30 usually. And what that means in terms of looking at a patient is they're incredibly sick. They have a high likelihood of dying on the wait list and not getting a transplant. Whereas patients in other parts of the country can get transplants with MELD scores in the 20s, which is a much more ideal time to do a liver transplant. So we have this discussion with patients in terms of where they are in the country and the risk of waitlist mortality, et cetera. We can offer them different types of organs, donation after cardiac death organs, fatty liver organs, high-risk organs. They do have the opportunity, though not everyone has the means to do this, to move to a different part of the country and be placed on a transplant list there. That requires insurance approval as well as financial and family support. And the third option that we discuss with them is living donor to liver transplant. So this is only about 6% of liver transplants in the US every year. A patient must be listed for deceased donor transplant, so they have had to go through the whole evaluation and be deemed an appropriate candidate. The ideal person is someone who has a prolonged time on the wait list with a MELD score of at least 15. Recipients for a living donor are less sick, so a MELD score of 15 to 20 is kind of the sweet spot where we know they'll benefit from a transplant, but they're not, they don't have a MELD of 30. It's usually a family member or an acquaintance that has a close relationship, and they're evaluated by a completely separate team to ensure there's no coercion. In general, in adults, the donor, they give up the right lobe, which is about 2/3 of the mass of the liver, and give it to the recipient. In pediatric cases, you can often use the left lobe, about 1/3 of the mass of the liver, for small adults or pediatric cases. So RS has multiple emergency room visits for a protuberant and painful umbilical hernia. There's been some concern for hernia incarceration. His MELD remains 19 to 20. General surgery sees him in the emergency room and recommends hernia repair, but they would like preoperative hepatology clearance. So RS has a perioperative mortality at 30 days following an elective hernia repair closest to which one of these? 1%, 10%, 30%, or 80%? Awesome. So the correct answer here is 30%, which looks like is the dominant choice on the questions. So how do we evaluate surgical risk in patients with cirrhosis? So fortunately, we use a couple of things that we've talked about already, the Child-Turco-Pugh score and the MELD score. Most of the Child-Turco-Pugh studies are from cardiac and abdominal surgical literature, so big cardiac or abdominal surgical surgeries. General rule of thumb, a patient with Child's A cirrhosis compensated has a 10% risk of mortality following a large surgery. A patient with Child's C cirrhosis has an 80% risk of mortality after a large surgery. The Mayo Clinic in 2007, and we still use this study, looked at patients with cirrhosis undergoing a broader array of surgeries. So they certainly had some large cardiac and abdominal surgeries, but they also had orthopedic surgeries, laparoscopic cholecystectomies, et cetera. And they looked at things in patients with cirrhosis like the preoperative MELD, their age, their ASA class. And what they found was MELD was the best predictor of 30-day and 90-day mortality. Basically, a patient with a MELD score of 12 to 15 still had a 25% 30-day mortality after any type of surgery. These are the patients like RS who has a MELD score of 19 going into a surgery. And more recently, the vocal pen score, which I'll show you on the next page, has been helpful in predicting both hepatic decompensation and risk of mortality following surgeries. And they look at the urgency of the surgery, the type of surgery, and also some patient characteristics: age, albumin, platelet count, bilirubin, their body mass index, their ASA class, and whether or not they have fat. And here is looking at the MELD score. So basically, our patient with a MELD score of 19 has a 30-day mortality approaching 35% and a 90-day mortality that's even higher from any type of surgery. And if you put in the vocal pen score, which you can Google, and putting in all of his things, they predict a 30-day mortality of about 12% and a 90-day mortality of close to 14%, but a good risk of hepatic decompensation, which he already has. So these are good tools. I tend to quote both the vocal pen score and the MELD score to patients to give them sort of a range. But I think it's often sobering to sort of think about this for each of your patients and calculate their actual risk from something that seems as straightforward as a umbilical hernia repair. So in summary, hepatic decompensation reduces survival. We use the MELD and the Child-Turco-Pugh score to predict 3-month and 1-year mortality in patients with cirrhosis. Though we use TIPS and large volume paracentesis in management of refractory ascites, TIPS is probably better long-term in select patients. When we're thinking about preventing hepatorenal syndrome, this includes things like giving antibiotics and upper GI bleeding or IV albumin in patients who have spontaneous bacterial peritonitis or are receiving large volume paracentesis. In patients with SBP, please stop their non-selective beta blocker for the period of the acute infection. Consider early TIPS in patients with Child's B and C variceal bleeds. Gastric varices are a little more difficult to manage, but have some local options for management, including glue, TIPS, BRTO, or endoscopic ultrasound coiling. The time to refer for transplant is a MELD score of at least 15 plus some episode of clinical decompensation. And when you're asked to estimate surgical risk in patients with cirrhosis, we have at our fingertips the Child-Turco-Pugh score, the MELD score, and the vocal pen score. Probably the MELD and vocal pen score are the most appropriate for most patients. And here are some references.
Awesome. A whirlwind full of information as usual, Dr. Rutherford. We have some great questions here from our participants. So the first question I have for you is around the use of diuretics when patients with cirrhosis kind of have soft blood pressure, and whether or not in these patients you ever think about using midodrine to facilitate the use of diuretics to manage their ascites.
I would say yes. I think it's reasonable to consider. I think if there's any acute kidney injury, I try and avoid using midodrine on its own, just because of the vasoconstrictive nature to not make things worse. But if you're trying to boost patients, these patients are very vasodilated in general, particularly as they develop worsening ascites. So I think it's reasonable to do that to sort of get their systolic blood pressure to a level where you feel comfortable giving them some diuretics.
Okay. Thank you. You had mentioned in the talk about giving vitamin K in the setting of acute bleeding. The group wants to know kind of what is your take on giving vitamin K just when patients aren't acutely bleeding, but they do appear to be coagulopathic, maybe their INR is elevated. Do you give it kind of before bleeding ever?
So I don't know if there's great data on that. I tend not to, because I think, I guess if patients come in with acute liver injury, acute liver failure, it's reasonable to give them vitamin K just to see if it's truly liver dysfunction or if they have nutritional deficiencies. But I think in the acute bleeding situation, certainly there's good data for it, and I think it can be helpful. Often it doesn't improve it that much, but at least you feel like you've sort of at least treated the possibility that there is a nutritional deficiency. But I tend to, I don't think that I would do it necessarily in just a patient that's being admitted for some other reason and they have an elevated INR. Unless you were worried, unless they had perhaps significant alcoholic liver disease and they may be nutritionally deficient. I mean, I don't think there's a lot of harm to doing it, but I don't think it's sort of standard management. And again, institutions will look at elevated INR and sometimes be reluctant to do different procedures. What I tried to convey is that's not a reason to give vitamin K, and there's no data to support the need for that in paracenteses and actually even in management of variceal bleeding or banding.
Okay, that's very helpful. There's a couple questions in here about beta blockers, and you touched on kind of the complicated nature of non-selective beta blockers for reducing the risk of esophageal variceal hemorrhage. Could you just review kind of maybe some of the transition points when we as generalists should be thinking about not reflexively restarting someone's beta blocker? Like, for example, you had discussed SBP as one reason to kind of pull it off. Are there other illnesses where you start to think about that?
I think as we are over the last year, there's been, a lot more discussion about, management of clinically significant portal hypertension and the use of non-selective beta blockers. So I think with the exception of acute SBP, so in the first few days, probably you want to defer on the side of restarting non-selective beta blockers. And if you can, I don't tend to switch people if they have been tolerating nadolol or propranolol. But if you're starting a new one, then starting carvedilol, which I think there's more data just that, it works and we don't have to be following it as carefully as we have with other ones. So I think for the most part, obviously, it's a little tricky when you're trying to diurese somebody and they're hypotensive, and you're giving them midodrine to sort of diurese them, I guess. But I think at the low doses, I think what we know about non-selective beta blockers is that even at low doses, they're probably having an effect on portal pressures where we might not be seeing an effect on systolic blood pressure. So if you're able to keep on a little bit, even in these patients like 3.125 of carvedilol, you're probably getting some benefit on their portal hypertension without compromising their systolic blood pressure. So I would say with that exception, I'd probably restart it as much as possible.
Okay, excellent. That's very helpful. You had mentioned sodium restriction as part of the management of ascites. What about fluid restriction?
So sodium restriction, definitely good data. Keeping someone to 2 grams per day and sort of discussing what that actually means, which is usually kind of eye-opening for people. Fluid restriction is not part of management of run-of-the-mill ascites. Ascites and hyponatremia, yes, but not management of portal hypertensive ascites. Okay,
excellent. There's a few questions about using DVT prophylaxis in patients who are admitted to the hospital, and kind of if there's any characteristics about these patients that may make you say, no DVT prophylaxis, other than acute bleeding, of course.
Other than acute bleeding. So I think the whole sort of INR versus coagulable state of these patients is really complex. So I don't think necessarily that an elevated INR, if you use sort of more advanced techniques like thromboelastography, et cetera, I don't actually think that these patients are as anticoagulated as we think. So I tend to recommend, in the absence of bleeding, that they be treated like other patients.
Okay. Excellent. And are there platelet levels where you start to think, because this often, I think we hear advice that's different from patients that have low platelets for other reasons. Is there like a platelet level where you're thinking, I don't know about DVT prophylaxis in this patient with cirrhosis?
I'm not aware of one, honestly. I mean, I think patients with low platelets, primarily from portal hypertension or hypersplenism, we don't often see them less than 20,000. I would say more typically we see them 50,000 to 100,000, and I wouldn't have particular concerns, but I'm not sure of any specific guidelines on that.
Great, that's very helpful. And then there are a few people who had asked about TIPS and hepatic encephalopathy and the mechanism behind why that predisposes those patients to encephalopathy.
So I think the idea is that even a patient with cirrhosis and decreased sort of ability to metabolize ammonia or proteins, if you are bypassing that sick liver, then you're completely removing the blood flow through that liver. You're completely removing any of the liver's ability to manage protein and convert, and ammonia levels.
Awesome. Okay, that's perfect. Our time is up. Thank you so much for the talk, for the awesome answers to your questions. We appreciate it always. Thank you.
Thank you. Take care.